Skip that. Can you see my slides now? Oh, yeah. Thank you so much for the opportunity. Thanks AOS and Dr. Namrata for giving the opportunity, and it's feeling very happy and privileged to share with the platform with eminent doctors over here and my beloved teacher, Dr. Ravikumar Reddy sir. So my topic is on post-cataract patient care, inflammation and dry eye perspective. That means we have to make the dissatisfied, unhappy patients happy. So over the years, we have come to this far in cataract surgery, from right from the amazing microscopes and pre-operative diagnostics and intraop diagnosis, which only to reinforce or improve the visual outcomes with outstanding fluidic machines, femtosecond lasers, and excellent IOL designs, and also the parallelly developed is the pharmacological innovations. So whatever is the form of cataract surgery, eventually you are going to have inflammatory response. So if you don't control the inflammation, end results will be in the form of poor visual outcomes. You can have delayed cystoid macular edemas, raised intraocular pressures, and corneal edemas, all these things. So the response has to be controlled either by using topical steroids concomitantly with the non-steroidal anti-inflammatory drugs. So I'm going to discuss about 3 scenarios here for the inflammation part. You all must have encountered toxic anti-segment syndrome, known as TARS. Although it is rare, but is as devastating as endophthalmitis because of its presentation. Until you get your gram-negative stains, cultures come negative, you get worried. And fortunately, it responds to the steroid medication. So once you encounter this situation, you need to have a complete analysis of your fluids, your instrumentation, everything to be reviewed, sent for the labs, and then also complete analysis, review of your OR and your sterilization methods. So, and this particular inflammatory thing, when it responds to steroids, but you need to be watchful of the endothelial cell toxicity. So you need to perform the specular microscope once the patient back after 3 months or 4 months, you need to do the specular cell count. So another scenario is the rebound iritis, which is pretty common. And the moment you taper the steroids, the patient comes back to you with back to the redness, pain symptoms, and they'll be worried, doctor, what happened to my eye? It's again the moment I stopped the medication. So in this, the risk factors, these recurrent uveitis with some autoimmune connective tissue disorders. So there the patient also understands and that been going through these recurrent episodes. So it is easy to handle these kind of scenarios, and you have a strategy here that you start your steroid medication as a preoperative cover, and also never ever do on a inflammatory eye. It has to be a quiet eye with a strategy of pre-op steroid cover. And other things, as already Dr. Gopala just said, very elaborately spoke about the floppy iris or rigid pupil scenarios. And then so in this, you are manipulating the iris so much, you want to get this rebound iritis. So sometimes, we see that we can get away from the not using the expanders. I'm more comfortable with the retractors than the ring. So I usually do this, but sometimes, it can get away. So you see there so much of manipulation. Your iris starts collapsing. You can't, your pupil, once it gets constricted, you don't see, you're unable to remove the nucleus entirely, and you miss out some cortex as well. And this much of, manipulation, you bound to get rebound iritis. And another scenario, see, once you miss this, you may see some fragment in the antechamber if you examine in the next day. And then sometimes cortex, which is missed out, probably you're unapproachable when the pupil gets constricted, or sometimes subincisional, it's pretty tough to remove. Then this cortex also will dissolve slowly, and you keep on getting these inflammations recurrently. And another scenario is where, you think you implanted the lens in the back, but one haptic might have sitting in the sulcus, which constantly rubbing the iris. And also, you should never keep the acrylic hydrophobic in the sulcus. So if there is any posterior capsule rupture, so always 3-piece is the best to implant in the sulcus. So once you deal with these kind of, scenarios, but then even then, regardless of that, sometimes you see this rebound iritis. So the strategy should be tapering from the stronger steroid to the weaker steroid will work better along with cyclophysics. It definitely works better. So this particular case, I just want to show you this. After doing a beautiful surgery, I implanted this lens, and the both optics got stuck to each other. And so how much ever I tried, I couldn't separate them. So I left it, and when next day patient comes with hyphema, and then, all these raised intraocular pressures. So eventually I did a AC wash and intensified the steroid medication. So here the loading was the problem. The loading did not happen well. So everything is essential. So need to understand the loading of these lenses. It's not the lens fault. And another scenario is this cystoid macular edema. Primarily, this rebound iritis is the extension of this cystoid macular edema is the extension of this rebound iritis. So apart from the, the risk factors, I'm showing one case which has a very hard rigid pupil and then hard cataract. These cases, all the complications may happen, jugular dehiscence or posterior capsular rupture, and then vitreous loss. So instead of, meddling like that, best thing is to do a straightforward SACS, but only thing was there was no nuclear drop, of course. All these things will lead to the cystoid macular edema. And apart from this kind of scenario, we have risk factors like diabetes, vein occlusions, either it's in branch vein or central retinal vein occlusions, and ERM. ERM has the tendency to develop the cystoid macular edema. So not that patient will have, from the grade 1 or grade 2, may not be having the visual symptoms, but you need to choose your lens carefully. Cannot put a multifocal because of it's prone for cystoid macular edemas. And also prostaglandin analogs for the AGMs need to be watchful. And of course, the incidence has been reduced. Primarily your cataract surgeries out with the great phaco machines, and your surgical excellence has been increased, not seeing much, and also because of the NSIDs, it's such a boon. So coming to the diagnosis of cystoid macular edema, sometimes it is may not be visible on clinical examination, but it can be picked up on the OCT, which is a non-invasive manner. And you can typically see the petalloid pattern on FFA. So coming to the management, so NSAIDs are the mainstay of therapy. And in steroids, when the topical and NSAIDs are not helping, you can give a PST. So intravitreal triamcinolone, you need to be watchful for the increased intraocular pressure. So now we have anti-VEGFs, which are really helping in recurrent cystoid macular edemas, especially patients who are diabetic. You see such kind of along with the diabetic macular edema. So they are very helpful. Another condition is retinitis pigmentosa. In our Telugu states, it's pretty common because the marriages happen in the consanguinity. So most of the kids will have this RP, and when they come for the cataract, you need to be very careful, because don't write it off that they already have constricted fields anyway, compromised vision. They may be having pre-existing CME, or they may develop CMEs post-cataract. So you need to have a close monitoring of that. And coming to the surgical management, sometimes, it may form VMTs. You have to have a pars plana vitrectomy depending on the situation. And coming to this, yes, there is more to this than meets the eye. The most appears simple, but it's more complicated. Because, cataract patient, as a refractive surgeon, counsel so much these youngsters when they approach for the laser vision correction. I tell them to, how important the artificial tears to be used post laser vision corrections. But never I really talk about this to my cataract patients. Mostly, talk about the how the procedure can be done, like use flags or MICS, and about the IOLs, what type of IOLs and all that. But probably because laser vision, it's an option. They can do any kind of thing, or they may end up with glasses. But if it is cataract, it is a compulsion. There's no other choice for them. Maybe we take it for a ride. We don't talk about too much about dry eye. So that's the reason that is being very underestimated, and the patient comes back to you cribbing about the foreign body sensation, stinging, or some kind of nagging pain all the time. Then we get alert and try to counsel them. But if you do that preoperatively, giving more chair time, like your refractive surgery patients probably, because cataract also is a refractive surgery. So what will happen in cataract surgery, the tear film instability because of the increased inflammatory cytokines, and they're already pre-existing meibomian gland dysfunction, which will be more aggravated. Because nowadays, it's all clear corneal incisions, so the nerve endings will be severed, more corneal sensitivity, reduced corneal sensitivity. And on top of it, using the topical drops will make so much of, SPKs and epithelium become more frail and fragile. So if you see this vicious circle theory, so the ocular surgery inducing the cytokine releases and MMP activation, which in turn there will be goblet cell loss. There will be tear film instability caused by this, and then hyposecretion. Then the pH has changed and hyperosmolality to cell apoptosis and delta. This is the cycle. Apart from the patients having a pre-existing connective tissue disorders, or of already laser surgery done, probably the laser vision, the LASIK done patients are the most easy to handle. They have already went through this dry treatment. But others, they crib a lot. And also we see so many antidepressants, people who've been on the antipsychotic drugs also will have these dry eye scenarios pre-existing. And we see so many times the conjunctival calluses. We always, try to pump them with lubricants, but still it is like a watershed, but we give them lubricants, artificial tears. That's very tough to treat. I don't know. You have to ask the panel about the congenital calluses, how to treat that, because they be with the most unhappy and dissatisfied patients who have these conjunctival folds. And there are questionnaires designed by this Ocular Surface Disease Index by Allergan and Ideal from Alcan, like impact of dry eye on everyday life, like McMoney's Dye Index. So this gives a kind of score so that you can decide whether patient is having no dry eye or minimal or moderate to severe. So if it is moderate to severe, maybe you need to delay the cataract surgery and plan it later by treating them. And also diagnostic tests primarily to differentiate the aqueous deficiency or there is a hyper evaporative status. So honestly, I don't do all this, but I think this is the need of the hour. We need to perform so that to make these dry eye situation to a pristine ocular surface. So what are the preoperative recommendations? We're not supposed to avoid this, preservative drugs. So we have now, but we are bound to use moxifloxacin, which is really epithelial toxic, although they say Vigamox is preservative free. But still we see that epithelial toxicity happening. And when coming to the, powdery drops as a prophylaxis for end off, I would rather prefer, treat dry eye than, not to end up, so we probably the powdery or other topical drops should be manufacturers think of using with the preservative free. And now we are also, picky about target emetropia. So we don't want our patients to have any kind of astigmatism. If it is not a toric IOL, we try to use arcade incision or LRIs or opposite clear corneal incision, which is much, very cheap, and you can minimal astigmatism up to 1 cylinder, you can treat them. So, and also because when there intense topical drops are being used, the epithelium become very toxic, and little manipulation, sometimes you create the epithelial defects. So all these leading to the aggravating the dry eye situation. And post-operative, what we have to do is the treating them with artificial tears, that too with the preservative free. And NSAIDs, again, I believe in, I'd rather treat dry eye rather than, ending up in inflammation. So I think there are a couple of Nepfinac preparations which are preservative free. I think Amplinoc is that, but not every Nepfinac is preservative free, of course. And when the patient is preferring the premium IOL, it is, even if not as a premium IOL, these IOL calculations mainly depend on your corneal pristine ocular surface. So it will disturb the outcomes as well. So treating them at least for a couple of weeks before planning the surgery, if you see any meibomian gland dysfunction or blepharitis, better to treat the patients first and then send them for the biometry. So coming to the treatment strategies like tear film instability, so there are artificial tear supplements and preparation to tear retention, and if there is a hyperosmolality, osmoprotectors are available. And I don't know about omega-3 fatty acids. I don't see much of them. There are studies supporting it, but the study also not very truly helpful. And coming to the immunomodulators, sometimes they are like restasis. It may be helpful for the when there is inflammation also concomitantly, it will help. And stabilization of lipid layer is the mainstay for the meibomian gland dysfunction. So these are the treatment strategies available. So to conclude, it is no longer considered just vision restoration. Now it is a kind of refractive surgery. So strict vigilance on inflammation with mandatory dry eye management protocol should be the standard of care. So that's how we can translate these dissatisfied patients as happy patients.